Hi there, folks. This is Dr. Ellenburg. Welcome back to another edition of our Medical Hour here on News Talk 1020 AM. You'll find us on FM as well at 95.5, and you'll find us online at 1020koan.com. That's 1020koan.com. You can live stream us. As always, if you have questions about your health or questions about someone else's health or questions about medicine in general, now is time to call. Our number here is 522-1020, 522-1020. As reminders, of course, during the week you'll find me at the Ellenburg Center for Natural Medicine. Our phone number there is 563-2366. Website address for our clinic is drellenburg.com. That's drellenburg.com. Check us out, list of our services. Other websites you might want to visit as well that are more about your health, and also suggested books you might want to look into learning more about as well. And again, it's drellenburg.com. I do see patients in the Kenai area monthly. If you want times and dates for those times, call our office at 563-2366. All right, well, we're got a big show here today and I'm going to discuss about. And the first thing they're going to get into you're talking about today is I found a really good site for talking about eating kind of gluten-free. And as many of you know, or maybe you don't know, who listen to the show or just turned the first time today, I've been pretty much, trying to eat gluten-free for, over a year and a half. And certainly at times I will, change things out and eat gluten-free. And so I guess the one thing to comment on, first of all, is what is gluten-free? And it's not just being wheat-free. It's being, avoiding barley, oatmeal or oats, basically. You are avoiding wheat. You wouldn't eat rye. You wouldn't eat things like, for example, bulgur, which is some type of a wheat, which is kind of like what couscous is versus quinoa. Quinoa is not a wheat product. And so there's been a big, I would say push in certain ways to encourage people with a variety of conditions to try and eat gluten-free and to see what will happen. And not everybody who has, some type of a gluten intolerance or a gluten sensitivity necessarily needs to have gastrointestinal problems. There's even been discussions in talking about in children with autism, even with adults or children that have ADHD, otherwise known as attention deficit hypersensitivity disorder, or ADHD, that food allergies can certainly play a factor in their brain health. In fact, we've talked on this show over the last year, maybe a little bit into last year, about two separate research articles specifically talking about looking at food allergies in people who have, and children as well, who have ADHD. And gluten seems to be the top of the list for a variety of problems that can, people who actually have a true gluten intolerance known as celiac disease that exists as well. But many of us who don't have celiac disease can still have a problem with gluten. Some of the testing for gluten allergies is highly inaccurate and not that effective at this point in time, I would suggest, as far as people being sensitive to it, as far as allergy testing. So I really recommend a lot of folks typically to try, going gluten-free for a period of time and not eating gluten and seeing what happens. Maybe their sinus problems will improve. Maybe their joint pain will improve. Maybe their gastrointestinal problems will improve. Maybe they'll have less brain fog. If they have an autoimmune condition like rheumatoid arthritis, for example, or or multiple sclerosis, which is not autoimmune but is kind of somewhere in between, we don't know. These are the kind of things to be trying to do. And the best thing to do is to eliminate it and then challenge that food, in this case, eliminating gluten. And that would mean things like you don't eat bread. You're not going to have oatmeal for breakfast, for example. You're not going to have crackers. I mean, there are gluten-free alternatives to those sort of things that exist, so you're not done eating things like that specifically, but you're not going to be eating, people are like, well, what do you eat? Well, there's plenty of things to eat. And so, as I mentioned, there's a site. It's called Gluten Freedom Project. So glutenfreedomproject.com. And I'll pull that up right now here. And they've got a whole list of recipes. There's an information site on here talking about celiac disease and gluten sensitivity or even food allergies. They even have, top-rated products and reviewed, brand products that are made gluten-free that people have rated as being, hey, this is a good product, and hey, it actually tastes good, because a lot of things that are gluten-free, as far as manufactured products, don't always taste the best. But you can find things that do. If you're trying to eat gluten-free, you want to have those crackers. I would say one thing with bread, it's hard to really find, I think, a good gluten-free bread that's a product. More or less, people have to make their own sort of things. But there are many things to be eating. Vegetables, you still get to eat meat. if you're being gluten-free, for example. So it's not the end of the world. And certainly when I went gluten-free myself, over a year and a half ago, I think, within a short period of time, I lost like 10 pounds out of nowhere. I mean, I wasn't even trying to lose weight, but it just came off on its own. And I can't say as to what they did. How have I felt since doing that? Well, I definitely tend to have less joint pain. And when I do go back to eating gluten more on a regular basis, I tend to have some gastrointestinal symptoms, maybe more frequent bowels, just not feeling the best gastrointestinal-wise. So, and I've been tested for gluten allergy, and since and they all came out negative. So it was only on my own of trying this out. But I think it's a great website. Again, glutenfreedomproject.com. So check it out. And again, if you try to eliminate gluten for a while, a typical recommendation in my opinion is 2 to 3 weeks, and then you can reintroduce gluten on a specific day where you'd have some bread products, have some crackers, eat some wheat, have some oatmeal, and then you wouldn't have any gluten for the next 3 to 4 days to see if you have any symptoms from doing that. And that's because if you have some type of a low-grade food allergy to gluten, you may not experience any problems for 24, even 48 hours. So that's definitely worth doing. And if you have inflammatory bowel disease like Crohn's or ulcerative colitis, you would definitely be worth your while to try going gluten-free for a period of time and see how things turn out. I've had a few patients do this specifically, and who had ulcerative colitis, and they were able to get off their medications for ulcerative colitis and no longer have ulcerative colitis because it was gluten that was heavily involved in part of their pathogenesis or the cause of their disease. Not all of it, but quite a bit of it. So again, Gluten Freedom Project, check it out. Worth learning more about. And if you don't, hey, I don't have any problems out there, why don't you try going gluten-free for a period of time and see what happens, see how you feel. The hardest part is called the willpower part, to actually eliminate, those things for a period of time and see how you do. On top of this, myself, I have a definite allergy to dairy, and I do avoid that. So, yes, I do miss things like cheese and those sort of things, but you know what? It's the way it goes. All right, again, folks, this is Dr. Michael Ellenburg. It's our medical show here on News Talk 1020 AM, also FM at 95.5. You can find us online at 1020kon.com. You can live stream us on the web wherever you're at. That's 1020kon.com. Questions about your health today? Our number here is 522-1020, 522-1020. Okay, well, let's go forward here and get started on a couple of topics. We haven't discussed vitamin D in a while. It's one of my favorite topics to talk about. And, what's interesting is even with the great summer we've had in Alaska, we are still having patients who, basically said, hey, I'm not taking any vitamin D. I've been out in the sun all summer. And it just so happens that they either were tested via our clinic or blood tested on their own or through their other provider. And many of them really don't have high levels of vitamin D. It really takes a fair amount of time in the sun to stimulate the production of vitamin D in your skin. And it is certainly worthwhile, if you do take vitamin D, to not stop taking it during the summer. You could take less vitamin D in the summer. That's a reasonable thing to be doing. And in Alaska, you only get any vitamin D production in your skin, again, from about the early part of May to about the middle part of September. And then after that, due to our tilt on the Earth and our latitude, how far north we are, the ozone layer actually absorbs ultraviolet B rays, or UVB, from the sun, and that's what stimulates vitamin D production in your skin. UVB is blocked, basically. So with that said, let's discuss a couple of studies here that came up recently. One here is discussing vitamin D and inflammation. And this was reported out of the Townsend letter and commentary by Dr. Alan Gaby. And it looked at a study of 2,015 patients who were referred for having their arteries of their heart imaged, and was called coronary angiography. And they had correlations were found between the levels of vitamin D and the patient's levels of inflammation. One marker that was used was known as C-reactive protein, which is an independent risk factor for cardiovascular disease. CRP, or C-reactive protein, is a blood test that can be done. And they also looking at levels of vitamin D. So if people had lower levels of vitamin D status, they tend to have higher levels of inflammation, in this case C-reactive protein. They also looked at the immune activation as well, with a marker known as neopterin, which is a more rare one looked at, but we'll focus here on inflammation as one of the keys. The commentary, Dr. Gaby is talking about that low levels of 25-hydroxy vitamin D, which is the blood test that is done to measure vitamin D, the main one being used, tend to be low concentrations tend to be found in patients with a variety of different medical conditions that are involved with inflammation or are involved with the immune system. And the argument is that people could benefit from taking vitamin D if they have those sort of problems. There are also some evidence that would suggest that people who have autoimmune disease, such as I mentioned today earlier, rheumatoid arthritis, multiple sclerosis, ulcerative colitis, Crohn's disease, a variety of different autoimmune and inflammatory disorders, they may be low in vitamin D. That has not always panned out in a lot of the studies. However, I would still suggest, specifically even the inflammatory bowel disease conditions such as Crohn's or ulcerative colitis, that due to digestive issues, patients might want to consider taking vitamin D as long as they have a place where they're actually starting from. So get your levels measured with the 25-hydroxy vitamin D. See where you're starting from. You may need to be taking a lot more than, first of all, the RDA for vitamin D. D is a joke because it's so the level is 400 international units or 400 IUs, so you don't get rickets, which is a disease associated with a horrible deficiency of vitamin D. Not even a minor one, but the terrible one. So most RDAs are not set up to help benefit your health. They're set to help keep you from getting a disease associated with the deficiency of that particular nutrient, in this case, vitamin D. With inflammation in patients, I certainly have frequently had people take higher amounts of vitamin D at certain times with inflammation, see if that actually will help them out, who have chronic pain disorders or have a chronic pain issue due to say a bad back, or they got a bad shoulder or a bad knee. That's a chronic problem that hasn't been helped from a variety of things. That trying higher levels of vitamin D might actually be helpful. And definitely, looking at vitamin D and depression can be quite interesting. And that kind of pairs into our second article. And this first article that I didn't mention, it came from the clinical and chemical laboratory methods. It's kind of a rare journal, but it is out there, looking at vitamin D levels paralleling with inflammation and immune activation was that first study I was commenting on. A second study, I didn't get the exact reference, but it was a study out of Norway that a team of investigators looked at depressive symptoms in people with low and higher levels of serum vitamin D, and wanted to find out whether or not if they were if by taking supplements could they improve their symptoms in those who had lower levels of vitamin D. And a sample basically of 230 patients who had low levels of vitamin D were assigned to receive either basically a sugar pill or get a vitamin D. And the vitamin D consisted of basically 40,000 international units of vitamin D once per week for 6 months. And 40,000 divided by 7, we're looking at pretty much about 5,500 roughly IUs of vitamin D3, in this case vitamin D per day if you average it out on the dose they were taking. Of 114 individuals with higher serum levels were used as control, meaning they were the people compared to, and they evaluated their depressive symptoms based on several different depression rating scales that exist out there. I won't bore you with what those are, but they do exist. And what they basically found out was the evidence is that those people who were more depressed, people who had low levels of vitamin D were more depressed than those with high levels, but in the intervention study, which they actually treated them, so they didn't find a difference by giving high-dose vitamin D. It's not to suggest that people shouldn't be trying that, but there are a lot of factors involved in depression that doesn't only necessarily involve vitamin D. This particular commentary that came out of Medscape didn't really go into what was considered actually a high level of vitamin D. In looking at laboratory ranges for vitamin D, we're talking about 30 to 100 these days, the low end being 30, high end being 100. I'm of the opinion that people should be somewhere around 80, high end, middle of the road, say 60 to get there. And even at 40,000 IUs once a week, most people will not become toxic. It is quite difficult to become toxic from vitamin D. It is a fat-soluble vitamin, so I'm not saying it can't happen. I'm saying that it can happen, and a fat-soluble vitamin means you actually will store that. So if you took vitamin D, for example, say 40,000 units a day, you will become toxic over some period of time, and that is not good for your health. So it's always good to know what's going on with this. I think the studies out of Norway would be very interesting to see what they're calling high levels, because Norway's, going to be in the same level basically as Alaska latitude-wise, and would be more prone to having vitamin D deficient people in their country as we'd have in here in Alaska and Canada for that matter. Definitely with depression, I do recommend patients having their vitamin D levels checked. I do also recommend that they have their levels of thyroid hormone checked in their body as well, and also a TSH, which stands for thyroid stimulating hormone as well. And yes, I would recommend in patients with depression that they may want to consider doing some type of a allergy elimination diet, because we do know as ADHD that food allergies can also cause symptoms that make you feel like you're depressed. I know it may be hard to believe, but it's very true, folks. And eventually out there we'll have much more of a more rounded approach, medically rounded approach in looking at depression. Obviously, it can be situational, it can be nutritional, it can be organic, going back to the thyroid, or going back to even food allergies. And I'm sure there's many things down the road as we go on in medicine. Later on, we'll find more things that actually can cause depression. And obviously, lack of sunlight is a big one of those things. And the people who feel that way, who have seasonal affective disorder, getting some type of light box for the winter is a great idea. I'm hoping since we had a great summer here in Alaska, people will have less depression this winter due to the great amount of daylight we had this summer compared to many past summers of recent. And again, I don't have a quote. I'm sorry, I don't have a reference to that article, but again, it appeared on Medscape. Sunlight, vitamin D, and depression. Definitely would consider recommending vitamin D in depression, as well as looking at other possible causes, not just that one treatment. So, all right, folks, this is Dr. Michael Ellenburg. Listen today is our medical show here on News Talk 1020 AM, also simulcast on FM at 95.5. And you can find us online and live stream us at 1020kon.com. That's 1020kon.com. If you have questions about your health, our phone number here today, of course, is 522-1020, 522-1020. I have no problem taking a break from what I'm talking about and talk to you about your health. Give me a call. We got about 5-6 minutes for the bottom of the hour break, so we got time for that. All right. Well, let's move on and talking about, let's see here. It's a shorter topic here for our timeline. Talking about anemia in patients who are elderly. And this anemia in general can cause a variety of factors. And this article appeared in the Journal of Neurology, published online last month, and entitled Anemia in the Elderly, a Potential Dementia Risk Factor. And again, it's always important to remind people when we say the word dementia, what does that really entail? People usually think it means Alzheimer's. Well, a lot of times it does mean Alzheimer's. If you were to write on a chalkboard dementia and then draw a line down and lines off the side from that, under dementia you will find Alzheimer's as the most common and frequent type of dementia found in the U.S. is Alzheimer's. You also have dementia related to vascularity of the brain. So people who basically have hardened arteries of the brain can also cause dementia. And also there is a dementia that can occur in people who have Parkinson's disease as well. But in looking at risk factors that can lead to dementia, anemia is one that has come up in this particular study that can be associated with increased risk of developing dementia. And this can be anemia due to either B12 or even iron deficient anemia. And B12 deficiency, I think, is very, very common in the elderly. And one of the main reasons being is that our ability to absorb nutrients from our food diminishes as we age, because our digestive capacity, that means our ability to actually digest food, can diminish over a long period of time. And so we don't have the robustness of our digestive system we did when we were 20 compared to when we were 80, for example, or even 60 or even 50 or 40 in a lot of people. And with B12 specifically, you have a factor in your stomach called gastric intrinsic factor that is needed to bind B12 from your food or even from a supplement you might be taking and help it get absorbed in your small intestine. And it's predicated upon the fact that the B12 will be bound to gastric intrinsic factor if you have good stomach acid output, because that will affect the secretion of this gastric intrinsic factor, which binds B12 in your stomach. So if you have low acid output in your stomach, you're not going to bind B12 very well at all. And guess what gets involved in that? People taking these long-term proton pump inhibitors, things like Acifex and Nexium and a variety of things. So we got a caller on line. Let's get to that. Greg, are you there?
Yeah.
Hi there.
Howdy. I'm 47 and recently diagnosed with pre-hypertension.
Okay.
Pretty good condition, generally eat well, but it runs in the family. All brothers and sisters and father on high blood pressure meds. Doctor started me on Vinicar, I think it is.
Okay.
I'm just wondering what alternatives are out there for that. And possible solutions to just weaning myself off the meds altogether.
Sure. How tall are you? How much do you weigh?
I am 5'10", 185.
Okay. So your weight's fairly appropriate for your height. And have you been screened for prediabetes?
No, I haven't.
Okay, so that's one that needs to be done. And one of the better ways of doing that, besides getting a fasting blood sugar, looking at glucose levels, would be to look at what's called a hemoglobin A1C. The acronym is the smaller one is HgA1C, or hemoglobin A1C, and that gives you a better picture of your levels of glucose over a 3-month period of time versus just looking at a snapshot in time of your fasting blood sugar.
Okay.
So that'd be helpful. And you also, if you were seeing me, I would also include a fasting insulin level with that as well, because if that's usually if someone's even early prediabetes, you might see an insulin level that's tending towards the higher end of what we call as a reference range for the lab. And these things can also increase your chance of developing high blood pressure, hypertension in this case.
Okay.
So there's one thing. So go ahead.
And let's say that that is the case for pre-diabetes. What would be the step in that?
Well, the big one there is going to be a dietary and exercise approach for sure. And if somebody is pre-diabetic, we look at things to help enhance their insulin sensitivity. And there's some trace minerals, for example, like chromium and vanadium help that out. Alpha-lipoic acid is also very helpful for just in general glucose and also for detoxification, but it's good for that. I also want to comment, too, if we get to the break, a few other things not involved in this directly, and that is looking at magnesium levels in your blood. A RBC magnesium would be important because that can affect blood pressure specifically and a whole bunch of other things as well in your body. But that's one I have patients we look at. And then also looking at potassium levels. So magnesium, potassium in a lot of patients are not at optimal levels, and that can also affect your blood pressure. So those are kind of the big ones. To kind of look at that could be done to kind of give more evidence as to why is this going on. I know you have this family history of that, but it doesn't mean you have to get it. But if there's reasons that are going to increase your chances, these might be involved in that.
Okay.
So.
And do you guys do the blood work, or we just
we do it at our practice.
For that?
You can go to a lab for that. We also do it at our office as well.
Okay. I have come in to see you in the past. In fact, I did a magnesium IV with you many years ago.
Okay.
But
give us a call. We have to go to break, unfortunately, here. 563-2366 is our number. But if you have more questions, hang on. Talk to you after the break.
Okay.
Okay, Greg. All right, bye-bye.
Now I find I've changed my mind and open up the door.
All right, hi there, folks. This is Dr. Elmer. Welcome back to the second half of our medical show here on News Talk 1020 AM, 95.5 FM. Again, you'll find us online as well at 1020kon.com. You can live stream us there, 1020kon.com. Got questions about your health, 522-1020, 522-1020. Thanks for the call there earlier, Greg. Sorry to cut you off there at the end. I think we covered most things, I think, for talking about high blood pressure. You know, there's a lot of things involved in it, but like I always say, organic causes, looking at potassium levels, looking at magnesium, seeing if somebody has any indications of prediabetes. These are things that people should be screened for before getting put on some type of hypertensive medication. You know, one thing I tell patients too, I think is worth commenting on. You know, I got out of naturopathic medical school in 2001, so that was 12 years ago, and probably middle way through our medical program, discussions on parameters for what is considered high, or pre-hypertension. Well, then it was 140 over 90. In the early 2000s, it's 130 over 80. Now it's 120 over 80. So, what we're not seeing, I don't think yet from the long-term data, is that people have to have blood pressures that low to prevent some type of cardiovascular event from happening. Certainly I am in agreement we have to have some type of a reference range to begin with. I'm of full opinion that probably 140 over 80. And if you're under that, and again, it depends how old you are. I mean, if you're 20 years old and your blood pressure is 140 or 80, you got something going on. If you're 75 years old and it's 140 over 80, maybe that's going to be some natural things that's taking place in your own body. As we age, our ability for our arteries to, your arteries, unlike your veins, have muscles in them, and they can flex and tighten, where veins do not necessarily do it that way. They have valves. They don't have a muscle that surrounds them. And as we age, blood pressure can go up. I'm not saying it needs to be 200 over 100, because no, that'd be bad news for anybody. But I think a lot of people are these days put on hypertensive medications far too early in the process, where we should be looking at more causes of why it's actually high versus take this pill the rest of your life. And that's how it works, right? You're on this for good. There's not a question of being on for a period of time. It's a question of being on permanently. That's how most this is being prescribed. So, great call, Gray. Thanks for your call. Appreciate it. We're discussing, again, question about your health. Again, 522-1020. Give me a call. No problem. Taking a break from my topics to talk to you about your medical questions. We were discussing anemia there prior to the break, and specifically in the elderly. And I was talking about B12 and that being involved with anemia. And iron can be as well. And what was found in the study looking at anemia in the elderly as a potential risk factor for dementia is that looking at someone's hemoglobin level, and this requires a little bit of discussion from them. So on a blood test called a complete blood count, or a CBC, you have one factor on it called hemoglobin measurement. Hemoglobin is a protein bound with iron, but it's found inside red blood cells, and it's how your body carries oxygen around. And so what happens is hemoglobin inside red blood cells binds onto oxygen when it's exposed to it inside your lungs. The alveoli are called, these little sacs of grapes that have vessels all around them. And then the red blood cells go throughout your body, end up in your capillaries to your peripheral tissues, and basically let go of the oxygen. And the hemoglobin goes back around with the RBCs back to the lungs and goes all over again. It goes on all the time, over our whole life, while we're alive at least. And so if your hemoglobin becomes low, your ability to carry oxygen is going to decrease, and that's going to cause fatigue, could affect brain function. And these are the main things happening with somebody who has dementia. They feel tired and worn out and lethargic, and they're anemic. They may even get short of breath because the hemoglobin's gone so low and they have so lower oxygen. So that's a big piece. And in dementia, as being a risk factor, that's one possible mechanism of being involved. Now, I mentioned B12 because one problem in measuring B12 is looking at serum B12 levels in the blood. They're not a very accurate measure. One reason why is because the range for that measurement is so large, 200 to 1100. And there's articles, I quote this article very often in the Journal of Orthomolecular Medicine that came, this was probably about 2 years ago, came out talking about how they were even seeing neuropsychiatric symptoms taking place at under 400 for B12. Things like brain fog, things like poor memory, just trouble concentrating, at 400 and under. and that was still in range. So again, this is really a big deal in looking at the B12. And this article appeared again in the Journal of Neurology. And what was done here is that about 2,500 adults participating in the Health, Aging, and Body Composition study who were free of dementia at baseline underwent blood tests for anemia and then followed for 11 years. Okay, and at what point is someone considered to have anemia? And we're going to base it on here in the World Health Organization's criteria. For men, it's around 13, and for 12 for women. And in my book, for men or women both, I want to see them around 14, say 15, 16 at the highest. But I want to see them in a better range. And they assess their function, their cognitive function, at certain years in this 11 years at 1, 3, 5, 8, 10, and 11 with a variety of different tests. One of them that's used by many providers, including myself, is a mini mental status examination. And you can find a test online and do it yourself. Well, it should be administered to you, but you can see some of the questions that are asked, and it's a rating scale. And basic diagnosis of dementia was determined on medication use for patients, hospital records, or decline on their score on the mini mental status examination. And what it showed from the results of the study is that approximately 16% of the population that was in this study had anemia at baseline, and about 18% of people in the study developed dementia during the follow-up. So say around 20%, so around 500 people over 11 years developed dementia. And the study's mean age at the beginning was 76, followed till age 87, which is quite up there. And and they adjusted for all kinds of risk factors involved in this as well. And he looked at C-reactive protein, which can involve inflammation, which can affect the brain, and basically looking at a variety of possibilities. Now, I mentioned B12, and I also mentioned iron, because if people have a bleeding disorder or have issues absorbing iron, they can also become deficient in that. However, on the other side of this, away from anemia, is looking at higher levels of iron, and known as hemochromatosis. And in people who have high levels of iron, and it's based on a blood test called a serum ferritin, and that ferritin is the iron storage form of iron. And any man over, say, the age of 35, 40, if you ever had this test done, you should have it done, because quietly iron can accumulate in various parts of your body, one being the brain, another one the liver, another one the pancreas, and your heart. And if your levels of iron get high long-term enough, they can cause problems, and they probably could contribute to Alzheimer's or other type of dementia-related diseases. So it's important to have it measured. And if you're a female who's postmenopausal, it also behooves you as well to have a serum ferritin test done to see where you're at. How do you lower iron? You give blood. It's that simple. In fact, mine's actually a little bit elevated at the moment in time. I'm due to start giving blood again. I've been giving blood for quite some time. I've been a bad boy in that direction, but I'm going to get back on giving blood more often. And that's how you keep iron levels low. Also, not using iron cookware would be a good idea if you tend to having higher levels of iron. So these are big things to consider. But certainly in looking at anemia in the elderly, and I have a number of elderly patients in my practice, we frequently can tend to see this kind of low-level anemia taking place for years and years, with a lot of providers not doing anything about it at all. They'll run a serum ferritin in the patient. Serum ferritin is normal. Okay, you're fine. You don't need B12. No, you probably need B12. Again, if you have decreased digestive capacity, you're not going to make enough of the factor that in your stomach that actually binds onto B12 to help with absorption, being a major issue. So if you're elderly and your hemoglobin is not near 14, get it that direction. Talk to your provider about why it could actually might want to have a little bit higher, and why it could benefit you. You'll have more oxygen available. You'll feel better. You'll have better brain function. A number of things. The same thing goes for someone younger than, say, the elderly. And so you might tend to have a lower level of hemoglobin long-term in your lab results. Get it looked at. Figure out why it's that way. Don't just live with it, because you're going to have a decreased capacity to enjoy your life in many different directions. Okay, and again, an article appeared in the Journal of Neurology, published last month, July 31st. Okay, questions about your health? Remember, this is our time day call. We got about 14 minutes left in today's show. Our number here at the station is 522-1020, 522-1020. Questions about your health, someone else's health, questions of medicine in general, give me a call. I'm happy to take a break from my topics and talk to you about yours. All right, well, we have some phone calls. We'll move along here. And since we're talking so much about B12 and issues, let's talk about an article that I know I talked about part of this article a couple weeks ago. I'm going to bring it up again, as it kind of goes off in many different directions to talk about many different topics. And this appeared Where did it appear? In the journal, No, on that page right there. I think it's the Journal of Integrative Medicine. But looking at antibiotics, looking at proton pump inhibitors, which are things like Prilosec, Prevacid, Acifex, Protonix, Nexium, things given for heartburn or GERD for that matter. And in this study, they were looking at seeing if antibiotics and if these types of acid blockers would increase the risk of people developing a diarrheal disease known as C. difficile or Clostridium difficile. And in this study, they looked at about 980 patients who had new onset of community-associated Clostridium difficile in 8 states, as identified through the CDC efforts, the Center for Disease Control. And it looked at a variety of things in assessing the risk factors for people developing this diarrheal infection. The bigger ones are being reporting, low-level healthcare exposure. So about 41% of that 984 people, or 400, had some type of healthcare exposure, such as a visit to a dentist or a doctor, while about 177 of them had no exposure at all that they could figure out. And that was reported in the Journal of American Medical Association, Internal Medicine Journal, don't have the month here, but earlier this year. They then ferreted out, okay, well, in those people who had this diarrheal infections, 980 of them, were they taking any medications? And then they looked at, say, well, 64% of them had reported using some type of antibiotic within about 3 months of the diagnosis of the disease, while about 30% of the people in the group who again developed this diarrheal infection, C. diff, reported using a proton pump inhibitor. And about 10% reported using a receptor antagonist, H2, which are the older drugs used for heartburn, such as Zantac, and Tagamet, for example. And just under a third of the patients had no antibiotic history at all that was involved or had any type of use of acid blocker in the previous 12 weeks. Well, so what we're talking about here is, why would that be the case? Why would you get a possible diarrheal infection after taking an antibiotic? Well, because you can kill off a variety of good, healthy bacteria in your GI tract if you have some type of infection. Remember, when you take antibiotics, they kill bacteria. They don't kill viruses. This is why they're not good for the flu, unless you have a secondary infection along with the flu, okay? But if you kill off a lot of good bacteria, and Clostridium difficile, or C. diff, tends to be a kind of a harder infection to kill off, where some more common antibiotics won't kill it off, it can allow it to not be killed in your GI tract, and you maybe have it on board as a carrier, and it can grow up to higher levels and then begin to cause some problems, such as having chronic diarrhea. So that's one piece. The other piece with this is talking about these proton pump inhibitors, okay? Things like Prilosec, Prevacid, Acifex, Protonix, Nexium. What do? They decrease your acid output in your stomach. Why does that matter? Well, because you can actually, be exposed to Clostridium difficile orally, in a sense. And the acid in your stomach is not just to help digest your food. It's not just there to help you secrete this factor that binds B12. It's also there at the level it's supposed to be to help kill off bacteria that are found in food. If we did not have such in a sense, a lower pH in our stomach, that's an acid, which in this case is a higher acid output, means lower pH in your stomach, we would have people have all kinds of foodborne illness much more often than it happens right now, okay? So by taking these different acid blockers long-term, Prevacid, Acifex, Protonix, Nexium, for example, you're increasing your risk of developing foodborne illness, and you're increasing your risk of developing other types of bacterial-associated problems with gastrointestinal problems. Okay, that's happening. And on top of this, what else are you doing? You're also increasing your risk of developing pneumonia, for example, because even that can be ingested in a sense. You're also increasing your risk of being deficient in B12 because you're not making enough stomach acid because you're taking a drug to decrease your acid output in your stomach. And that also affects nutrient absorption, such as magnesium, okay, and other trace minerals your body needs for health. And if you don't get enough B12 into your body, you can increase something in your body called homocysteine, which is an amino acid that can damage your arteries of your heart and other arteries in the rest of your body and cause cardiovascular disease. And if you don't absorb your nutrients well from your stomach, because you're taking an acid blocker for years and years and years, you increase your risk of osteoporosis and bone loss. So why are you on these things, right? Well, they were developed for short-term use, these acid blockers. They were not developed for long-term use. And by the way, you might have the heartburn or having the acid problems in your stomach because you may not make enough stomach acid in the first place, and that causes your heartburn. It needs to be looked at in these patients. Now, yes, you can also have bacteria known as H. pylori or Helicobacter pylori. So if you have chronic GERD or heartburn, you need to be tested for H. pylori. It's a blood test. It can be a stool test as well. It can be a breath test as well to rule that out. If you have it, it can be treated to get rid of it. But all these things play a factor again in developing other types of infections. And we definitely tend to see people taking, way too much these proton pump inhibitors. I mean, you can even buy, products like over the counter now. People go in the store and say, well, I've got a heartburn. I'll take this stuff, and I'll take it long term. Well, long term, if you take it for years and years, you're going to have problems. And what's considered long term? More than 1 year. Okay, I'm not talking 10 years. I'm talking more than 1 year. So it's very important to understand that part of that. And that you don't want to be on your health. Okay? And if you have issues like a hiatal hernia, for example, where your stomach valve isn't closed properly, that needs to be corrected. And there's ways of looking into that. If your sphincter, which is one of the valves on top of your stomach that closes it so the food won't regurgitate up into your esophagus, or the cardiac sphincter is not closing properly, it might be due because you don't make enough stomach acid output to signal the body to close that valve, which is part of the issue. And two, if you don't make enough stomach acid in the first place, your food will sit longer in your stomach and not be digested as well, and that will also in turn cause heartburn. Okay, so it's a very complicated picture that requires, different viewpoints of looking at it, and possibly even seeing your gastroenterologist and getting scope. It's called endoscopy down your throat to look at your stomach to see what is going on exactly. So many factors involved with all this. And again, this article that we're getting back to infection. Today's show, you got questions about your health, give me a call here. It's 522-1020. It's 522-1020. We had on one topic I came across here, which is my favorite, magnesium again. When I find something this is worth reading about. And again, this article appeared in the Townsend Letter and its commentary with Dr. Alan Gaby, and talking about magnesium for epilepsy. And in what they call a retrospective chart review, meaning where they basically went through a bunch of charts in patients, in this case 22, not a whole lot, but enough, in patients who had drug-resistant epilepsy, meaning they were treated with drugs that were not working. People decided in these patients to try and use magnesium empirically to see if it would help. And in most cases, the magnesium for epilepsy was given at a dosage of 400 times a day, which is a pretty big dose. They then measured their mean seizure frequency, how often it happened, days per month. And what they found in this small group, but still effective, was they had about a 33.3% decrease at the first follow-up. At the second follow-up, 50% decrease over this period of 12 months. So half the patients had a serious decrease in their seizure frequency monthly just alone by taking magnesium. And 36% of the patients had a reduction in their seizure frequency of at least 75%. And 2 were seizure-free after 1 year by just taking magnesium. Side effects from the magnesium, and some did cause diarrhea. That can happen commonly, so you take it in divided doses throughout the day. And Dr. Gaby's commentary on this is talking about that magnesium deficiency can cause seizures and can increase stimuli of increasing susceptibility to experiencing seizures. They've even known to be using IV magnesium has been used for seizures in young children, and also it's been used in people experiencing seizures with alcohol withdrawal as well in some older research. In previous research, there's also known well that magnesium concentrations in the serum and also in cerebrospinal fluid are much lower in patients with grand mal epilepsy than those who do not have epilepsy. So again, a finding that would suggest that some patients who have epilepsy might benefit by taking magnesium and may have, as he puts it here, suboptimal. So it would seem quite reasonable that anybody who has epilepsy that you may want to look at trying magnesium. And furthermore, I'd recommend getting a blood test, a red blood cell RBC magnesium test, and see where you're starting from. A serum magnesium test is highly inaccurate in a sense because the serum magnesium test, your body is trying to maintain a certain level at all times in the serum, versus in red blood cells, it can vary a lot further. And we've used this test, the serum magnesium, for years, for a long time. And when I switched over to using the RBC magnesium, I started finding a lot more patients who were deficient in magnesium versus before. So I think it's a great test. And it seems that, one, magnesium is inexpensive, and secondly, it does not seem to interact with anticonvulsant medications, and so it can be considered quite safe to be used along in patients who are receiving medications for epilepsy. So what a great article to come up, and this article appeared. Where did it appear? Usually he quotes that. I didn't quote that. Oh, I'm sorry. Well, nonetheless, be considering magnesium, epilepsy. It'd be a great thing. And beyond that, on a more simpler note, people who develop leg cramps, night charger horses, you should consider taking magnesium. Again, if you have them chronically, get your blood measurement done. You might need to take more than you think. And yes, if you take too much magnesium, it can cause, and beyond that, it can cause diarrhea. So, okay, that part be careful about, but very, very safe. And today we also discussed the use, looking at magnesium and high blood pressure. I have discussed in the show over the last year 2 different articles looking at atrial fibrillation and magnesium levels in these patients, and those who tend to have higher levels of magnesium tend to have less atrial fibrillation. How about that? And just so you know, magnesium is involved in at least over 300 reactions we're aware of currently in the body. So your body uses magnesium a lot daily, and that's why people tend to be more deficient in that than, say, other minerals. But magnesium is a big one, and we use quite a bit of it in our practice with some very good success for a variety of things. Even for sleep. Even people use it for they go to bed at night and can sleep a lot better as well. So consider that. We've got about 2 minutes left in today's show, I think. If you have questions, now is plenty of time, unfortunately, to call, but you can get back over here on Mondays, 2-3 p.m. We're on here. You can find me at the Ellenburg Center for Natural Medicine. Our phone number there is 563-2366. Our website online is drellenburg.com. That's DRELLENBURG.com. You can check us out there. And what's the takeaway today? So today we discussed about vitamin D and depression, worthwhile thing to be using with that. And I would recommend highly having a 25-hydroxy vitamin D test done to see where you're starting from. And also with inflammatory disorders, or if you're prone to chronic infections, or even prone to colds or flus, get your vitamin D levels measured. It's a really big deal, and it's easy to have the test done. Insurance will pay for it. If you pay out of pocket, you shouldn't pay more than, say, $70 at the most for it. We also mentioned today a great website called glutenfreedomproject.com. Glutenfreedomproject.com, all one word. If you've been told to be gluten-free, here's where you want to go to learn more about first of all, what is gluten sensitivity, recipes that works, and brands and products that are gluten-free. Check it out, glutenfreeproject.com. I do appreciate the phone calls today. And again, we're on Mondays from 2 to 3 p.m. Have a great week, and we'll talk to you next Monday. Take care.
A former bride and a former groom, a folding table and a folding chair, a folded hand, a poker there. All new directions must go everywhere. Big round people in a cool little square. Or you can cut it with a boat or a plane. Man, it's gonna take a new train. You'll be leaving on a new train, far away from this world of pain. And when you look out your window, you'll see your home, your baby, and your family.